morning. Everybody ready? Okay, Thursday morning pediatric grand rounds. Dr. Green is one of our pediatric intensive care physicians, and she is going to update us on the new pediatric sepsis guidelines.
I feel so important to be introduced. Okay, so this is breaking news. This is first time ever that we've actually had some evidence-based pediatric guidelines published, and it was published last month, February, in 2 journals. So I wanted to just introduce it, go over it. It's actually like a 50-something page document of things. If you would like to look it up, peruse it, you're welcome to. Have no disclosures. I was not involved in this either, in developing these. So learning objectives, we're going to talk about, we're going to define septic shock, sepsis-associated organ dysfunction in children. Children, I mean 37 weeks born at least 37 weeks all the way up to 18 is their definition for that, but not including neonatal infections. Discuss evidence-based process for developing practices, so how they came up with these guidelines, these statements, these suggestions, and then also we're going to run through them. Now, there's 77 statements, so we're going to breeze through them quickly. We'll get through as many as we can. So like I said, it's the title of the guidelines that were published, Surviving Sepsis Campaign, International Guidelines for the Management of Septic Shock and Sepsis-Associated Organ Dysfunction in Children. And so it was published last month, Pediatric Critical Care Medicine, and is also published in Intensive Care Medicine. You can also go to survivingsepsis.org, which is a website that is by the Society of Critical Care Medicine, and that you can also get information there. So, as we know, sepsis infections in kids is one of the leading causes of morbidity, mortality, and healthcare utilization for children worldwide. And so that's why they felt like it was very important to address this. In 2001, they developed the Surviving Sepsis Campaign, and it was actually the Society of Critical Care Medicine that developed this, and they started with all the adults first. In 2005, we have our pediatric sepsis definitions. That's the last time they were updated. I've heard they are pending new definitions, as far as what we're calling sepsis. They did just release, well, not recently, I guess, but 2016, Sepsis 3 is the new adult guidelines. They got rid of the term severe sepsis. There's a lot of different little nuances and things. So I think pediatrics, the new definition, should be coming out soon. So what we have now, like I said, in the adult world, they've gotten rid of severe sepsis. But what we have now for peds, the latest guidelines, or the latest definition, is 2 or more SIRS criteria. SIRS criteria are based on temperature, high or low, heart rate, respiratory rate, leukocytosis, okay? And then also confirmed or suspected invasive infection, cardiovascular dysfunction, ARDS, or 2 or more non-cardiovascular organ system dysfunctions, such as renal failure, liver insufficiency, all the other things that we see associated with sepsis. Septic shock is a different definition. Septic shock is where you have cardiovascular dysfunction, and that is evidence of hypotension, impaired perfusion, requiring vasoactive meds. That is shock, okay? And so it's 2 different things. So what I wanted to do, I hear a lot of people say, oh, this kid's septic, but they don't have any SIRS criteria. They have no other criteria. So bacteremia does not mean sepsis, just by the way. That is not the definition. It's not bacteremia, okay? But it's more likely overwhelming infection, and you actually see the patient responding to that and have altered things. So for these criteria, so what they did is these people took and reviewed all the literature. And for these criteria, they said that you either have septic shock or they called it septic-associated organ dysfunction. And that's what they divided them into 2 categories for just a broad overall. And all their recommendations are based on these 2 categories. So, of course, septic shock is when you have cardiovascular dysfunction, like we talked about, hypotension, requiring vasoactive meds, impaired perfusion. Sepsis-associated organ dysfunction is pretty much everything else. They still meet the sepsis criteria, and they can have other non-cardiovascular organ dysfunction. So that's the two categories that they divided in as far as the recommendations. So the Surviving Sepsis campaign, starting to look at pediatrics. They've established all their adult criteria, updated the definition. So now this was a panel of 49 international experts representing 12 international organizations. So this was a big process. They divided the panel into 6 subgroups, and I'll talk to you about the different groups and what they did. And then they provided 77 statements. Now, there are not all recommendations. We'll talk about that too. Some of them are best practice statements, or in our practice we have this, and it's regarding the management and resuscitation of children. The important thing is this is all evidence-based. They reviewed all the literature on each topic. So the 6 subgroups that they looked at was recognition and management of infection, hemodynamics, resuscitation, ventilation, endocrine metabolic therapies, adjunctive therapies, and then the last group was actually an evaluation of where are we missing data, where does we need to do further research to make actual recommendations. They used a grade approach quality to look at the evidence, and they graded the evidence from high to low, depending on what evidence there was, what case studies they reviewed. And that is based on risk of bias, inconsistency, indirectness, imprecision, publication bias, and balanced risk versus harm. And then they came up with their statements. The classification of recommendations, so they could not, based on data, they could not make recommendations on everything. So they said, and they classified each recommendation. Is it strong, weak? Is it a best practice statement, or in our practice? So strong would be they had high or moderate quality of evidence. Okay. Weak recommendation is if there was any evidence available. They said it was weak. Best practice statement is pretty much what everybody does, standard of care per se, but they could not find evidence for it. And then in our practice was where there was no evidence at all. It's not really standard of care, but what these experts actually do in their practice. Okay, so get ready, grab your coffee, put your seatbelts on. We're going to review these very quickly. And like I said, what they do when they publish these guidelines, for each statement, they give you a rationale. And so there's a pretty detailed rationale on what studies, how they came to the statement. So I do not have time to go over every rationale for every statement. So if you really want to go back and review, or you have a question about a few of these, please go back and look at it, and they'll give you the rationale for each one. Okay, here we go. First of all, screening, diagnosis, systematic management of sepsis. So it says, in children who present as acutely unwell, we suggest implementing a systematic screening for timely recognition of septic shock and other sepsis-associated organ dysfunction. So basically there needs to be a systematic way to find these patients, diagnose these patients as early as you can. Now, they could not recommend what tools, what screening tools. They said it's based on your resources, it's based on the patient population, it's based on what your facility can do. So they said that there needs to be some type of systematic screening. They just couldn't recommend which tools to use. One of the big things that come up in the questions is lactate. They said that they could not issue a recommendation about blood lactate levels. There's just not studies, there's not evidence for this. But it says, however, in their practice, that if it can be rapidly obtained, it's just another tool to help you, right? If your lactate level's elevated, most of the time you're not perfusing, okay? The kid's in trouble. And so it's a way to help you, but there's no data on any of that. And a lot of places can't get a lactate. They said that they recommend implementing a protocol guideline for management of children with septic shock and sepsis-associated organ dysfunction. It's a best practice statement. So there needs to be straightforward guidelines, mainly so you recognize it early and can act on it early. They also recommend obtaining blood cultures, but only if it does not delay antibiotic therapy. Antibiotics is the number one. Blood cultures, if you can get them beforehand, it's great. So antimicrobial therapies, we're moving to a different section. It says in children with septic shock. Now these are patients that are hemodynamically compromised. They recommend starting antimicrobial therapy as soon as possible, of course, and they recommend within 1 hour. So these are the patients that you should be able to recognize shock pretty quickly. They have impaired perfusion, they're hypotensive, they look terrible. Okay, they said antibiotics should be within 1 hour. And that's actually a strong recommendation based on what they found. Now, patients that have sepsis-associated organ dysfunction, so they're not hemodynamically compromised. Sometimes it takes a little bit longer to recognize evidence of sepsis. They recommend starting antibiotic therapy as soon as possible, but they try to put a window within 3 hours. So it gives you a little more time to evaluate and figure out what's going on. And these patients aren't quite as sick. So usually it's getting your labs back, looking at them, seeing what's going on. So they had several best practice statements. They recommend empiric broad-spectrum therapy to cover likely pathogens. So if the patient has a big abscess, if they have a septic knee, things like that. Tailor your antibiotics, but you always start broad-spectrum initially. Then once the pathogen sensitivities are available, you need to narrow your therapy, which is what we try to do. Okay, we try to assess each day, why are these patients on these antibiotics? Do they still need them? What are we treating? And you narrow it down so you don't breed resistance. It says if no pathogen is identified, that's not uncommon, that we don't get an organism we don't know, then they recommend either narrowing, stopping antibiotics based on the clinical presentation, the site of infection, host risk factors, adequacy of clinical improvement in the discussion of infectious disease specialists, which that's where our ID people help us. But you just need to narrow down. You need to assess. So there's 2 recommendations. So you have your septic patient that comes in without immune compromise, no high risk for multi-drug therapy. It's not a patient that visits a hospital. It's not one of our chronic patients. They suggest against the routine use of multiple antimicrobials. Okay, used to, back in the day when I was training, we would quote unquote double cover gram negatives. If we thought it was a gram negative infection, we would often double cover things. That is no longer the case if their immune system is intact and they don't have a risk of multi-drug resistance. On the other hand, if you have a patient that is immune compromised, or they're one of our chronic patients that come in and they're at high risk for multi-drug resistance, then they said it's okay to to use multi-drug therapy. And this is the initial medication. They recommend, also you've got to think about when you have a patient that comes in with sepsis or septic shock, a lot of their pharmacokinetics, pharmacodynamic properties, meds you're given. If they have renal failure, you need to be careful about what dose you're giving. So they said to be sure when you prescribe antibiotics that you alter how you give the antibiotics, the timing and things based on the patient. Also, they said that they want daily assessment for de-escalation of antimicrobial therapy. So that's pretty much standard. That's what we teach y'all. Each day it needs to be evaluated. Does this patient still need these antibiotics? Can we narrow down the spectrum? What are we treating? What are we doing? And that's that's a patient by patient decision. They recommend duration. So look at duration. Don't just keep patients on antibiotics from here on out. You need to look at your duration. It's based on the site of infection, the etiology, the response to treatment. They actually suggested using procalcitonin, your white blood cell count, things like that to evaluate how the patient's responding. And the ability also to achieve source control. Do we get the knee drain, the septic knee drain? Is the line out that was causing the infection? Things like that as to how long we treat. But you need to have a duration in mind at some point. You don't want to just continue antibiotics. Okay, source control. Emergent source control intervention be implemented as soon as possible after the diagnosis of an infection. So that's you have your septic joint, it needs to be drained. You have an abscess, it needs to be drained. You have empyema, it needs to be drained. Things like that. You need to achieve source control as soon as possible. They talked a little bit about IV access devices. And we get line infections from time to time. I think a fungal line infection, you have to get it out no matter what. Some of the bacterial line infections, it's usually a patient that has a difficult way of establishing new access. or sometimes we treat antibiotics through the line, depending on this patient just with difficult access. So it's patient by patient basis. The ideal thing is to get the line out, but sometimes that's just not always possible. Okay, fluid therapy. This one is a very controversial one. It's been controversial for years. What was interesting is they divide the fluid therapy recommendations in whether there's ICU available or not ICU available, which I thought was very interesting. It says in healthcare systems with availability of ICU, they administer up to 40 to 60 mils per kilo per bolus fluid over the first hour. Now you look to see, that is 10 to 20 mils per kilo per bolus, then with reassessment in between. You don't just, when the patient arrives, give them 40 per kilo of fluids, okay? This is a patient that's in septic shock or sepsis-associated organ dysfunction. Okay, so that's the initial resuscitation. I think the main thing is when they first came out with the adult guidelines, they started giving these adults 40, 60 mils per kilo. It was their first bolus. And they didn't go back and reassess, and all these patients started getting fluid overloaded, and it was a huge issue. So I think the main thing is they were very careful in how they worded this, and that you should start with our normal 10 to 20 cc's per kilo, but you have to go back and reassess before you give more fluid. Go back and see if there's any response. Make sure they're not having any evidence of volume overload before you give them the next bolus. So like I said, they have recommendation based on whether you have ICU or whether you don't. So they're a lot more cautious if you do not have ICU available, as in you're probably not able to assess them for volume overload as well. So if there's no availability of ICU and there's no hypotension, they don't recommend giving any fluid bolus at all. They just recommend putting them on maintenance. And these patients are normotensive. These are not your really sick ones that come in. And that's with no ICU. So that won't be RER here, but these outlying hospitals that are calling you, don't tell them to give them a bolus. They probably don't need a bolus if they're not hypotensive. That is what they're recommending. Also, they're saying if they have no availability of ICU and they're hypotensive, that's a different situation. So we start fluid resuscitation. But they recommend administering up to 40. Remember, the other one was 60. This one's up to 40, but it's also 10 to 20 mils per kilo per bolus. And so it's going back, reassessing, look at your clinical markers of cardiac output. What is your urine output? What is your perfusion and all? And then you need to watch for fluid overload in these patients. Another thing that has been a big thing in ICU and critical care is crystalloids versus colloids. Big debate, year-long debate. They recommend using crystalloids rather than albumin for the initial resuscitation of children with septic shock or other sepsis-associated organ dysfunction. The reason is the cost, and it is the ease of administration. Because with albumin, you have to get a filter. It's harder to get. They said, though, also that people that got albumin versus crystalloids, there's no difference in the outcome. So it's normal outcome, but they went ahead and recommended crystalloids first. Okay, so this is all initial resuscitation. The other thing that was interesting they've come out now with is we suggest using a balanced buffered crystalloid rather than normal saline. So patients that are resuscitated with normal saline, we know they get a metabolic acidosis. It can cause acute kidney injury. And it can also cause inflammation in itself. So now they recommend, even though it's not real cost effective, but they recommend using the balanced or buffer crystalloid. So that's like Plasmolite, LR, things like that as your initial resuscitation fluid. They recommend, so we used to use, I don't even think we have it in the hospital anymore, we used to use head-of-starch, Hespan, for resuscitation. I've never used gelatin in resuscitation, but these are just other volume expanders that are available. I don't think we have them here, and they actually recommend not using either one of them. Okay, hemodynamic monitoring. It says we are unable to issue a recommendation about where to target the MAP on a patient, the mean arterial pressure. Okay, is it between the fifth or 50th percentile? Is it greater than the 50th percentile? So they could not make a recommendation. There's just not data out there. What I have found is you have to look physiologically at the patient. A lot of them will tolerate a lower blood pressure, and you look at their lactate. Are they tolerating physiologically? How are they doing with that blood pressure? So look at the whole clinical picture rather than having a beautiful normal blood pressure on the monitor. So it's looking at the patient, and seeing physiologically what do they need, what are they tolerating, and all. We don't have to have all perfect numbers. We're learning. We also used to, back in the day, is we would classify shock. A patient would come in with shock, and we would classify them as warm or cold shock. Whether, they were clamped down, they had no, what I'm talking about, whether they were clamped down, they had no peripheral perfusion, or whether it was warm shock, and then we would use that to kind of guide therapy as to what we would do. And they said that is not helpful at all. It doesn't correlate with anything, so don't do that. They suggest using advanced hemodynamic variables when available, in addition to clinical variables, bedside clinical, to guide the resuscitation of kids. So look at everything. They recommend, invasive blood pressure monitoring if needed, an A-line. They highly recommended also about using serial echoes to look at resuscitation of these patients, and look at their cardiac function and things like that to help if you have it available. But you've got to just look at the whole patient. They actually suggest trends in blood lactate levels. Lactate levels help us out a lot in these patients to see whether, we use them a lot in the trauma patients too. Are they adequately resuscitated, or they're still not? Is there something else going on? So we follow lactate levels quite a bit here. Of course, we have them readily available, easy to get. Okay, vasoactive meds. This is another thing that's changed. We used to always use dopamine. Patient was hypotensive, we'd put them on dopamine. This has changed. Now, they're now suggesting using either epinephrine or norepinephrine, okay? And those are using those over dopamine. So dopamine is not first choice anymore in these patients. We still get a lot of patients from outside hospitals. They put them on dopamine, have them maxed out on dopamine before they even start anything else. So it's kind of updated evidence. They could not say whether to use epi or norepi first, so based on the data and what they had. So they said it's basically clinician, facility, what we use. Here we use norepi first. Okay, used to we wouldn't use norepi. It was, what was it, leave a fed, leave them dead, is what it used to be called back in the day when we used dopamine first. But things have changed, and patients actually do better. So epi or norepi is supposed to be your first line therapy. They also could not issue a recommendation. They looked at the question of whether we can use it in a peripheral access. We talk about, we got to put them on pressors, we got to get a central line. So that's the ideal situation. But if you have a patient that's not doing well, that needs pressor support, it is okay to initiate pressors through a peripheral line, hopefully a large peripheral line. But we do the best we can, and it's okay while you're in the process. These outlying hospitals, they can't put in central lines. So tell them, go ahead and start it, peripheral line, send them on. The other thing that has also changed here recently is when you're titrating up your catecholamine, say that you're on a max dose of epi or norepi and pretty good doses, is now we add vasopressin at low dose. And vasopressin has been very effective in helping. So if you have a patient that's requiring moderate to high doses, you can add vasopressin, and that will also help. They could not issue recommendation about using an inodilator. So that would be milrinone, dobutamine. So they could not find evidence about using those. But they said in their practice, if you have patients with septic shock and persistent hypoperfusion and cardiac dysfunction based on your echo, then they use those agents. They're not first line, okay? But they couldn't really issue a recommendation based on the evidence. Okay, move on to ventilation. They could not issue a recommendation if you have a patient that is septic shock, is fluid refractory, so not responsive to fluids, and is not responsive to epi nor epi. They could not issue a recommendation on whether or not to intubate these kids. I've had a few kids that are on high dose vasopressors and things like that. We never intubated them; they never needed it. So they couldn't issue a recommendation. Most of the time, those kids, if they're that sick, most of the time they get intubated. You're going to want an airway. The other thing recently is do not use etomidate in kids. So we don't use etomidate in the unit anyway. We use Versed, fentanyl, propofol, whatever we need to use. Etomidate, there has been some recent data showing that etomidate can actually suppress your adrenal function and cause adrenal suppression, especially in patients with shock, which that you can have it anyway underlying in patients in shock. So that's the reason not to use it. So they're not recommending etomidate. So if you have a patient that is doing pretty well, responding to initial resuscitation, but having tachypnic, a little bit of respiratory failure, they said you can suggest a trial of non-invasive mechanical ventilation. If it looks like they're going into ARDS, and they use the term PARDS, P-A-R-D-S, as pediatric ARDS, just by the way. That it's okay to try non-invasive first, and then maybe you can get that patient turned around quickly, and they won't need to be intubated. But when you use non-invasive, you have to go back and reassess the patient pretty often, and make sure they're tolerating it, they're doing okay on it. They also recommend if the patient is intubated, using high PEEP, and that came out of all the ventilation studies about using, higher PEEP and low tidal volumes. Is safer on the lungs, splint those alveoli open. Recruitment maneuvers, I don't know if y'all know much about this. The patient that is intubated on the vent and is just severely hypoxemic. And so recruitment maneuvers are like a stepwise approach. There's several different ones. But for example, it'd be a stepwise approach to increasing your PEEP. And then it's down, decrease your PEEP. Recruitment maneuvers, you're recruiting alveoli is basically what you're doing. You're trying to get those popped open and then you splint them open. Okay, so but they could not find any evidence for or against that. I don't think there's much adult evidence either for that. Sometimes we do it, sometimes we don't. If you can't get the patient sat up, then you may at least try it, okay, as long as you know what you're doing. It is now pretty much standard of care if you have a patient with refractory hypoxemia on the vent to do prone positioning. And prone is so much easier in kids than adults. Adults, it's a whole big rigmarole, big deal. A kid, you little kids, you just flop them over. Not a big deal. It's pretty much now standard of care to do prone positioning before escalating to other things. Inhaled nitric. So we used to use inhaled nitric quite a bit here. We now use Flolan. I think this applies to either one, but they recommend against the routine use. So you don't automatically put all these patients in ARDS on nitric or Flolan, okay? But we can use it as a rescue therapy. So you have a patient who has evidence of pulmonary hypertension on their echo, or nothing else is working. Try it. And if it doesn't work, guess what? Stop it, okay? But they don't recommend just the routine use of putting patients on it. The other one they reviewed was the high-frequency oscillation ventilation. And they could not issue a recommendation on that either. Okay. So I think it depends on your facility, what you're comfortable with, if you want to try it or not. And these are patients who are severe ARDS on the vent, and they're just hypoxemic, and you still can't get their SAT up. You can't oxygenate them. So you start looking towards other things. Neuromuscular blockade. Back in the day, also, we used to paralyze everybody. Everybody got paralyzed. Now we try to get away from that, not do as much, do the shortest amount of time as possible. So they suggest using those in patients with severe ARDS. And we do that so we can control everything that we can. Steroids. Steroids is another big hot topic in the treatment of sepsis. So they recommend against using IV hydrocortisone in patients with septic shock if fluid resuscitation and vasotherapy are able to restore their stability. So you pretty much reserve steroids for those patients who do not respond to therapy. Okay, kind of like a last resort, let's try some steroids. So it says we suggest that either IV hydrocortisone or no hydrocortisone may be used if they're not able to restore the hemodynamic stability. So it's quite controversial whether we use steroids or not. Okay, usually we're looking towards it if the patient's just not responding to traditional things. Okay, endocrine. So there's also a big thing about blood sugars, and especially adult patients. They did several studies on optimizing blood sugar. Where should your blood sugar be? Do patients do better if there's tight control of blood sugar? So there were a couple studies that came out in the adult patients and said if we have very tight control, the better you control the glucose, the better the patients do, as far as insulin therapy, IV drip, things like that. So what they also found, though, is these patients had more episodes of hypoglycemia. So several more studies came out and said they had more episodes of hypoglycemia, which is actually detrimental and increases your mortality. So they recommend against using insulin to maintain a blood glucose target at or below 140. Okay, so they've kind of loosened, they don't want strict control of blood sugar. It does not help because they have more episodes of hypoglycemia. But what target should we have? They don't know. They couldn't issue a recommendation. So we don't know where it should be. They recommend keeping it below 180, but they don't know where the lower limit is. You just got to make sure the patient does not get hypoglycemic. Blood calcium levels, they said they could not issue a recommendation of whether to normalize blood calcium levels. Now, we have patients, and this is in our practice, we often target normal calcium levels for patients that are on vasoactive support. So usually if they're on pressors, we're getting blood gases and we'll get ionized calciums. And if we're still having trouble keeping their blood pressure up, even on the vasoactive meds, then we usually give calcium. And you pretty much see an immediate response if they're going to respond to it. So, but it's to normalize their calcium level, but it's usually only those patients that are just persistent hypotension, requiring a lot of pressors. The other one they looked at is the sick euthyroid state. Okay, a lot of patients that come in have sick euthyroid. They do not recommend replacing them, and we typically don't replace them with thyroxine. Doesn't help. This was kind of interesting to me. We suggest either antipyretic therapy or a permissive approach to fever in children with septic shock. So basically, you can either treat the fever or not. You know, there's two camps. Fever is beneficial, it's helpful. Fever is not good, it increases your metabolic rate, it decreases your seizure threshold. I think it just depends on the physician, the patient, and go from there. So there was no recommendation they can make on that. Okay, moving on is nutrition. Okay, so there were some very interesting things on here. So they were unable to issue a recommendation about early feeds, about starting slow, titrating up. I think everybody is in agreement that feed as early as possible, okay, and they recommend enteral feeds. I'll talk about that in a minute. So there's a preference to do that, and I think majority of people, probably best practice, or they said in their practice, is a stepwise increase. Make sure they're tolerating it. And that's typically, I think, what majority of people do. Now, is there evidence to support that? No. It says we suggest not withholding feeds solely based on vasoactive inotropic medication. So we feed these kids. You know, we're careful about it. We watch them very closely, but just because you're on a pressor does not mean that you can't feed them and go ahead and start feeds. And that used to be the case. Everybody thought, oh no, they're on a pressor, we can't feed them, they're not perfusing anything. But we go ahead and we also feed our ECMO patients. We did a study here actually on our ECMO patients and early enteral feeds. So patients do well with that. The other interesting thing is we suggest enteral nutrition as the preferred method of feeding, and that parenteral nutrition may be withheld for the first 7 days. So you have a week to feed, basically. Now you want to feed as early as possible, okay, according to what the patient is doing if the patient's stabilized. But, there's no reason to start TPN early. They're saying actually give it 7 days. Try to start enteral feeds in those 7 days, and then if you cannot at that point, start TPN. TPN is not a benign thing. If you don't know what you're doing, if you don't monitor electrolytes quickly, they can get fungal line infections. It is not a benign process. Enteral is best, okay, unless you just absolutely have gut surgery or whatever, that you can. But they give it up to 7 days, which is kind of a little bit different than what our ped surgeons do. They're ready after day 3 of starting TPN. I'm always like, no, hold off. We can wait. If you're going to feed in a couple of days, let's just wait. Patients are okay, okay? We have tried several things to treat patients with as far as sepsis, to try to make things better. There's specialized lipid emulsions, omega-3, things like that, and they have not been shown to be helpful. But there's several studies out there that try all kind of additives. The other thing is we suggest against the routine measurement of gastric residual volume. So if you're feeding the patient with the NG tube, which we used to do all the time, we would measure gastric volumes, every 4 hours to make sure they're tolerating it. And studies have shown that doesn't make any difference of whether it was a big thing, when you measure the volume, you take it out of the stomach. Do you return the feed? Do you not return the feed? I mean, it used to be this whole big deal. Now they're saying don't even measure it. It doesn't matter. So they hold a little extra food in their belly, go by a clinical exam, what they look at, that they don't have any increased incidence of vomiting, aspiration, things like that. So they do not recommend against that. The other thing that's interesting is they recommend enteral feeds through a gastric tube rather than a post-pyloric tube. So standard, we do post-pyloric tube. The reason for this is that they showed no difference. There was no increased aspiration pneumonia. There was no increased vomiting. Patients tolerated it just fine. Now, this is peds. Tolerated it just fine. But what they did find is if you were using post-pyloric tubes, that there was a delay in feeding, that the patients didn't get fed as early because of getting the tube, placement of the tube is a big deal. And so there was a delay in feeding, and that's why they recommended gastric, and it didn't show any difference. I think our practice here is we feed pretty early, all our patients. We do post-pyloric, but it's not, I don't feel like it delays but by a few hours. Get the nurse to put it down, get an x-ray, look at it. So that being said. They also suggest against the routine use of prokinetic agents. So we used to use Reglan, the Metro, I can't even say what it is. And all. So we used to use those things, and they have not been beneficial, and they also can cause QT prolongation. So it's not even worth using, because it doesn't really help, and it can cause QT prolongation. So like I said, that there are so many studies out there about giving patients selenium, arginine, extra vitamin C, vitamin D, and all during sepsis to see if they do better, and none of the studies have panned out. Nothing helps. So they recommended against all those. So those are each a separate recommendation. I just summarized it. So basically none of that helps. All right, let's move on to blood products. Blood products. We suggest against transfusion of red blood cells if the blood hemoglobin concentration is greater or equal to 7 in a hemodynamically stabilized child. Okay, so we've learned a lot about giving patients blood. You give them blood, it can depress their immune system, it can do a lot of things. And so we always try to teach y'all that, if you want to give blood, don't look at a number, look at the patient. Now, okay, yes, if it's 5, please give them blood. But look at the patient. Do they physiologically need it? Are they tachycardic? Are they having a hard time oxygenating? Look at the patient. Do they need this blood or not? And then you're going to outweigh the risk and benefits, of whether you want to give them a transfusion or not. Higher hemoglobin does not help your survival of sepsis, is basically what they're saying. It says that they could not make a recommendation on those kids' thresholds. They used 7 in the one before, but children with unstable septic shock. Who knows? Who knows? We're probably more likely to keep the hemoglobin higher, at least 7, but higher if the patient's unstable. And we need volume, we need red cells. So a lot of these patients that are septic have low platelets, right? You come in, platelet count 40, 50, 60. They do not recommend just transfusing automatically with platelets. Does not help, okay? This is an infectious process going on. This is some DIC. This is giving them platelets is not going to help. So in patients, they don't recommend prophylactic use of platelets. Now that being said, of course, if it's, your threshold 10 to 20 and they're high risk of spontaneous bleeding, yes, we give them, okay? But other than that, if they're not bleeding and there's no risk of bleeding, we just let it be. And as they get better, you will see their platelet count will recover. Same thing with plasma transfusion. A lot of them have a prolonged INR and a coagulopathy. If they're not actively bleeding, there's no reason to give FFP. Doesn't help. they wanted to make a statement about plasma exchange. So we do plasma exchange here, but it is only indicated if the patient has what we call TAMOF, which is thrombocytopenia associated multi-organ failure. So if you have a kid comes in septic shock and they're holding their platelets up, we do not exchange them. Okay, it's only found to be beneficial in patients that have TAMOF, is what we call it. But they said they cannot suggest or against the use even if they have TAMOF. They could not find evidence. What we do here is if they have evidence of TAMOF, we exchange them. Renal replacement, okay? So they recommend using renal replacement, like CRRT, to prevent or treat fluid overload in patients that don't respond to fluid restriction and diuretic therapy. So basically, if you need it, use it, okay? They do suggest against, we used to be doing some high volume hemofiltration. We thought, okay, we're filtrating all the bad stuff, right? And that has not been shown to be effective. So they just recommend the regular, normal volume hemofiltration, and it's mainly for fluid management in these patients and renal failure. Okay, ECMO, all right? They suggest using ECMO, veno-venous ECMO, in children that have refractory hypoxemia. So, you know, we moved toward ECMO earlier. If they have severe ARDS, we can't get their SAT up, you're not going to keep using your vent, beat their lungs up, make things worse, cause more inflammatory response in the lungs, cause lung damage, things like that. We just go to VV ECMO, okay? And then patients, you can also use VA ECMO. So VA ECMO, veno-venous ECMO is vein-vein. You pull from a vein, return to a vein. Veno-arterial ECMO is where you pull from a vein, return arterial, and you can actually provide some cardiac support. Okay, so it's a higher level of support. And basically it says, yes, you can use VA ECMO only if you have septic shock refractory to all of the treatments. So basically it's a rescue therapy. But we do tend to do it earlier rather than later. Okay, IV immunoglobulin. We suggest against the use of the routine use of IVIG in children, septic shock, sepsis-associated organ dysfunction. So majority of these patients do not need IVIG. It is not shown to be helpful. Now, there are select patient populations, select infections where it may be helpful, may or may not. So that's where you get ID to help you. And those two patient populations are toxic shock syndrome, especially if it's a strep etiology, and also necrotizing fasciitis. Okay, and those two patient populations, they may benefit from IVIG therapy. But just the routine use, no. Prophylaxis. So this has also changed here recently. They suggest against the routine use of stress ulcer prophylaxis in critically ill children with septic shock, sepsis-associated organ dysfunction. So we found that these meds that we use, if we just put everybody on the stress ulcer prophylaxis, that they have been shown to have an increased incidence of pneumonia, and they also have an increased incidence of C. diff. Okay, so they don't recommend routine use. Now, if you have a patient that has a gastritis, that has blood coming out of their NG tube, if they're at high risk, if they're on steroids, if they're on a lot of vasopressor support, if you have still high risk populations, we do go ahead and prophylax those patients. But routine, no. So you have to look at your patient, look at all the patient factors and see if you need that or not. The other one that's interesting is the DVT prophylaxis. So they suggest against routine DVT prophylaxis, and this is mechanical and pharmacologic. So they do not recommend that. But again, you look at your patient population. If you have an obese patient on birth control and they have underlying cancer, things like that, you may want to go ahead and do DVT prophylaxis for those patients. They also talked about the specific patients with, most of the pediatric DVTs that we see, they're line associated. They have a femoral line, they have a IJ, something like that, and they'll get a clot from their line. I think it's mainly what we see as far as peds, unless they have an underlying coagulopathy. But I think you just have to look at your patients. But we don't even routinely do DVT prophylaxis even if they have a line in place. Not all those patients, very few of those patients actually get clots. So last, I actually finished this pretty good. The last subgroup of people looked at, okay, what do we not have evidence for? What could we not make strong recommendations for? And so they want to look at recommendations for future research, where we need trials, where we can make things better. And so they want to identify gaps that can inform future research. Okay, that was a lot. We actually got through all of them. So I think it's just important that we now have some evidence-based guidelines, and then you can, like I said, you can go back and review. It's a pretty extensive thing, but it gives you a rationale for each of the recommendations. And so I think it kind of helps us to do something actually evidence-based. What is proven is helpful. And they have agreed they're going to go back, I think, every 4 years and review these. Go back and look at the data and have updated guidelines. That's what they're doing for the adults. I think they'll probably do that for peds too. But this is the first time we actually have recommendations, some guidelines on what to do for pediatric sepsis. All right, do y'all have any questions at all? No questions. Okay, all right.